what is the commonest site of involvement of tuberculosis is lungs. So pulmonary tuberculosis is the most common presentation other than extrapulmonary. What are the extrapulmonary sites? Commonest extrapulmonary sites are lymph nodes, GI tract, CNS. These are the other most common extrapulmonary site for involvement. It can involve, TB can involve any part of the body. TB can involve any part of the body. So anything bone, spinal cord means vertebral canal, that can be involved in extrapulmonary tuberculosis. These are the Mycobacterium tuberculosis complex. You must remember this name. This is asked, can be asked as a short note, can be asked in the oral. Mycobacterium tuberculosis complex compressed of Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium africanum, Mycobacterium capri, Mycobacterium microti, and Mycobacterium cannati and Mycobacterium pinipidi. So these are now laboratory diagnosis of tuberculosis. You have already done your practical class, sputum for Zeden stain or acid fast stain. But in recent era, with the advent of molecular test, we are always going for upfront CBNAT or molecular test to diagnose the tuberculosis. What is the advantage of molecular test? One is you can diagnose TB because in sputum, it is 10 to the power 4 bacilli per ml is required to get it positive. So sensitivity is lower than the molecular test. And second part is we can know the rifampicin resistance at the same time. So let's start with laboratory diagnosis. So what are the main principles of diagnosis of TB? One is try to establish the microbiological confirmation in all cases. Previously in past, sometimes we use the empirical anti-tubercular drug, but with advent of diagnostic, so molecular tests are coming up, so we are not trying to give empirical anti-TB treatment without any microbiological confirmation. The first principle is microbiological confirmation of all cases. Use rapid molecular diagnostic upfront wherever possible for diagnosis of TB and early identification of resistance to treating drugs, and focus more on quality sample collection and timely transportation. So sample must be proper, optimum sample, quality sample collection and timely transport. So these are the three main features that is given in National Tuberculosis Eradication Program for diagnosis of tuberculosis. Now when you can say which patient you will prescribe the test for TB. What are the clinical features? Patient will come to you. So the main patient with cough for more than 2 weeks, with or without fever, with or without hemoptysis. So main features, any patient coming to you with cough for more than 2 weeks, tuberculosis should be excluded. So person with cough for more than 2 weeks is a presumptive pulmonary tuberculosis patient. They are to refer to designated microscopy center for sputum examination and patient belonging to key population. When you suspect extrapulmonary tuberculosis, HIV or pediatric age group, go directly to CBNAT. So this is the second principle. When it is you get a patient with cough for more than 2 weeks, you exclude tuberculosis. Now this is a new case definition. Previously it was called patient TB suspect. That term has been changed. What is the new term? Presumptive TB. So what is presumptive TB? Who presents with symptoms, signs suggestive of TB. Previously known as TB suspect. What is that? Cough for more than 2 weeks. That is presumptive tuberculosis. Next, presumptive pulmonary tuberculosis, signs of cough, fever for more than 2 weeks, significant weight loss, patient living with HIV, having diabetes. These are cancer or immune suppression drug at any moment. They are presumptive pulmonary TB. Presumptive extrapulmonary TB, any person with organ-specific sign, lymph node swelling. What would be the character of lymph node in tuberculosis? The lymph node will be in a matted lymph node. Matted lymph node, more than one lymph node attached with each other. When you feel a tubercular lymph node, you will never forget in life how the TB lymph node palpates. That is common term is matted lymph node. Next is joint pain, swelling, constitutional symptom like fever, weight loss and night sweat. So fever, weight loss, night sweat is common to whether it is a pulmonary TB, whether it is an extrapulmonary TB. Next, pediatric tuberculosis. What is pediatric tuberculosis? Children with cough and fever for 2 weeks. This is the first. Second is significant weight loss. If the child has lost more than 5% weight in the last 3 months or no weight gain in last 3 months, you should exclude tuberculosis. Next is contact with infectious TB case. A family member or a neighbor having an active pulmonary tuberculosis. So pediatric TB is first is fever and cough for 2 weeks, then weight loss more than 5% in 3 months or without any weight gain. That is a presumptive tuberculosis case. That already I have told. Upfront rapid molecular diagnostic test. What rapid molecular diagnostic test? It will be asked everywhere. What is the molecular diagnostic test? That is CBNAT, cartridge-based nucleic acid amplification test. Advantage, first is turnaround time is only 2 hours. You can get the result only 2 hours. You also get to know the rifampicin resistance also, so that we can modify the treatment. So this is the diagnostic algorithm. Everything, this is in single chart. What you should do, whenever any presumptive TB case, sputum smear examination and chest X-ray to be asked. If it is smear positive and chest X-ray suggestive of tuberculosis, then it is next is smear positive but chest X-ray not suggestive of tuberculosis, smear negative but chest X-ray suggestive of tuberculosis. So these are the cases where you need to send to next level. This smear negative but it is chest X-ray is suggestive of tuberculosis. What is the chest X-ray that is suggestive? Last day I told. What chest X-ray, which part of the lesion will occur in which part in tuberculosis? In adult tuberculosis, not the prime in children. What is the common X-ray finding? Common X-ray finding is the involvement of the upper lobe. Involvement of the upper lobe, that is common in tuberculosis. So any shadow in the upper lobe or any cavitary lesion, that is suggestive of tuberculosis. That is suggestive of chest X-ray. Next is smear negative, chest X-ray not suggestive. Then clinical suspicion of high. Clinical suspicion high, where in pediatric cases, weight loss, where patient having fever, which is not subsiding in spite of other treatment for more than 2 weeks. These are the cases where suggestive. Then we go for CBNAT. PMDT criteria. What is PMDT criteria? Programmatic Management of Drug-Resistant TB. PMDT. Programmatic Management of Drug-Resistant TB. And those cases should go to, even if it is near positive, you send it for CBNAT. Don't start treatment in the last NTEP, which is started from 2020. Before starting treatment, always do a sensitivity test. So if it is near positive, previously when it is near positive, we start treatment. But now we go for CBNAT, even if it is near positive, so that we know the rifampicin resistance. This is the same algorithm for the diagnosis. Programmatic Management of Drug-Resistant Tuberculosis in India have been released in March 2021 in World TB Day. Programmatic Management of Drug-Resistant Tuberculosis. The new guideline have considered emerging diagnostic trend, TrueNAT or GeneXpert. Both are these TrueNAT and GeneXpert, both are CBNAT. These are the two commercial names. Either it is a TrueNAT or GeneXpert. So don't first utter this name, TrueNAT or GeneXpert. You utter CBNAT. Then if it comes the commercial name, this commercial name are either TrueNAT or GeneXpert, which are available. And after that, next generation sequencing and whole genome sequencing is a new method for diagnosing, which is costly and not available in most of the centers. Now, why we are so important to know the resistance? Because the MDR TB is increasing in our population. Multi-drug resistant TB is on a rise. Microbiological confirmation. A presumptive TB case, you have asked for a sputum sample, proper sputum sample, then you do a Jill-Nielsen stain or a fluorescent stain. Which fluorescent stain is usually used? So positive for acid-fast bacilli or positive for microbiological confirmation. So when you are asked how you confirm, so these are the three ways. One is positive for acid-fast bacilli either by Jill-Nielsen stain or fluorescent stain. Next, positive for Mycobacterium tuberculosis on culture, and positive or TB through rapid diagnostic molecular test. Now, how long it will take to grow in a solid culture media? Now, clinically diagnosing TB, which I was mentioning, empirical antitubercular treatment should be limited to very few patients, where in spite of high suspicion, microbiological confirmation could not be established. Entire diagnostic algorithm puts almost utmost effort to diagnose tuberculosis. Now, here is third point, demonstrating hypersensitivity to purified protein derivative. What is the test? It is called Mantoux test. How much Mantoux test? What it diagnose? Mantoux test, do it diagnose tuberculosis? What is the implication of Mycobacterium Mantoux test? Usually 5 tuberculosis unit PPD protein purified derivative is used. What it diagnoses? It does not diagnose tuberculosis, it diagnoses exposure to tuberculous bacilli previously. Exposure to previous tuberculous bacilli, that is not of diagnostic of TB. Mantoux test, what it diagnoses? It tells us whether the patient is already exposed to Mycobacterium tuberculosis. How will you read the Mantoux test? You have intradermal injection of 5 tuberculosis PPD. What you will look after 48 hours? It is read after 48 hours. What will you read in Mantoux test? What it occurs? Induration, redness, maybe ulcer. So usually what we read? When you call it positive, you in the highest diameter, you measure it with a scale. If it is the induration, not the redness or other thing, induration is more than 10 millimeter after 48 to 72 hours, then can call it Mantoux test is positive. So when Mantoux test is positive, it will be induration you should measure after at least 48 hours. It can be measured between 48 to 72 hours, but induration should be more than 10 millimeter. What is the new test? What is coming up in Mantoux test? Another test is coming, it is being done nowadays. It is interferon gamma release assay. What it diagnoses? It specifically diagnoses one thing, exposure to TB or patient having latent tuberculosis. So interferon gamma release assay is more specific than Mantoux test, but it is costly. As we are still in a developing country, so we cannot afford to give IGRA in all patients, but USA, Mantoux test is not done, only IGRA interferon gamma release assay is done. That is more specific to diagnose the exposure to tuberculosis. What is quality sample? How many samples will you collect? Latest NTP guidelines gives 2 samples. Spot when the patient visits you first time and ask him to come next morning. So spot sample and the next morning sample. This is the 2 samples you have to give. Any request form from Jeden stain or acid fast stain should accompany 2 samples. So what are the 2 samples? Recently discharged material from the bronchial tree with minimum amount of oral and nasopharyngeal material. Presence of mucoid and mucopurulent material, what would be the optimum volume? 2 to 5 ml. Sputum should be collected in a white mouth container. Should you ask him to gargle with antibiotic? Oh, antibiotic gargle? You should ask only to rinse the mouth with plain water. Don't use like chlorhexidine gargle or betadine gargle before giving sputum. So just ask him to rinse the mouth with water and then ask him to cough out the mucopurulent sputum, don't give just the saliva. So the specimen is collected in a sterile container, white mouth sterile container, after the rinsing the oral cavity with clean water only. The specimen should be packaged and transported to the laboratory as soon as possible. There is no transport media. There is no transport media for sending the sputum, but should be packaged and transported to the laboratory as soon as possible. 2 samples I have already told. What are the other samples for pulmonary tuberculosis other than sputum? Children who cannot cough, you can give some gastric lavage. Laryngeal aspirate or bronchial washing, gastric lavage in small children less than 2 years who cannot cough. So gastric lavage can be given because they usually aspirate the sputum. Next is what is done with the sputum. Decontamination and concentration method. When you receive the sputum in your laboratory, what is the first thing to do? You can do directly go for Jedenstein or otherwise do, and this term you should remember, decontamination and concentration method, because the sputum also contains other bacteria other than tuberculosis. So if we want to get the tuberculosis in culture or in sputum AFB more simply, then we have to do the decontamination and concentration method. What is the most common decontamination and concentration method used? These are the few methods. Petrov's method. Petrov's method, what is the chemical used in Petrov methods for decontamination? It is 4% NaOH. After 4% NaOH, it is basic, so you have to neutralize with hydrochloric acid, 8% HCl. So if you use Petrov's method, you have to use the 4% NaOH and neutralized by HCl. But what is the commonest method is used? NAL combined with 2% NaOH, N-acetylcysteine. What is the advantage of N-acetylcysteine? Sometimes you can see in some cough syrup, you can get this N-acetylcysteine that liquefies the sputum. So if the acid-fast bacilli is entangled within the mucoid part of the sputum, that can be liquefied by using NALC, N-acetylcysteine, along with 2% NaOH. So this is the concentration and decontamination method. What are the staining method? One is Gill-Nelson staining method. We have already done in practical. 25% or 20% H2SO4 is used. In NTP it is written 25% H2SO4. If you tell 20%, it will not any harm. So 25% H2SO4, that is the decolorizing metal, it is a material that is used. What are the other methods for staining the sputum? Quinoline modification. What is the quinoline modification? In Jedenstein, what you need to do? You have to heat the carbol-fuchsin so that it penetrates the mycolic acid. Without heating, it won't penetrate the mycolic acid. What is the content of carbol-fuchsin? Basic fuchsin plus carbol. Carbol means phenol. So what is the concentration of phenol in carbol-fuchsin? It is usually 5%. In quinoline method, we don't heat. It is not always used for sputum, it is used for acid-fast staining of other material also. That is why quinoline has developed. Heating is not required. So what is done so that it can penetrate the mycolic acid? The concentration of phenol has been increased from 5% to 8%. So that is the cold acid-fast stain quinoline method, where the concentration of phenol is increased from 5% to 8%. But the focusing is with 100x. Now auramine, rhodamine, fluorescent stain. In district tuberculosis center, which stain is commonly used? Fluorescent stain. Now what is the advantage? What is, either it can be auramine, rhodamine, which I have written in the slide, or it can be auramine O. Auramine O or auramine, rhodamine, that is stain. What is the advantage of fluorescent staining? Anybody? How will you, what is the advantage? Why it is utilized in distal? What is the disadvantage? You need a fluorescent microscope. Fluorescent microscope is costlier than simple microscope, but still we use the fluorescent staining because we look in the fluorescent staining at 40x. So 40x, wider area can be scanned in a single. That is the advantage. The whole site can be scanned very quickly. So 40x, the magnification used for looking in the auramine O or any fluorescent staining is 40x. and bacilli will appear as bright blue. I show how it looks. Now this is again the grading. More than 10 per field is 3 plus. So if you get a clump of bacilli, it is 3 plus. Whenever you see a clump of bacilli in a field or in other field, that is 3 plus. Then 1 to 10 per field is 2 plus. 10 to 19 per 100 field means 1 bacilli per field, that is 1 plus. And 1 to 9 bacilli per 100 field is scanty. So no AFB in 100. Why I have written 100? I should have only have written no AFB. So you have to scan at least 100 fields before calling it negative. You have to scan the whole slide for 100 fields before calling it negative. So this is the grading for NTEP. This is the culture tube. Still gold standard for diagnosis of tuberculosis is culture. What is the media used? This is Lowenstein-Jensen media. And the colony usually appear after 2 weeks. It takes 4 to 8 weeks to culture to grow. Usually in other bacteria, 24 hours incubation is enough. But it takes 2 to 8 weeks. Why? Last class I discussed about generation time. Generation time of E. coli is 20 minutes. It is 20 hours for tuberculosis. And Mycobacterium leprae, it is 20 days. So Mycobacterium leprae usually cannot be cultured in a growth media because the generation time is high. These are few liquid media. What is the advantage of liquid media? It grows quickly in 20 days or 2 weeks or 3 weeks, and it is used for drug sensitivity testing. The liquid media mostly used for drug sensitivity testing. So name few liquid media: Dubose media, Middlebrook media, Proskar Box media, Sula's media, and Sotus media. It is sometimes asked in the exam or oral, what are the liquid media used in Mycobacterium tuberculosis? Name newer methods: automated culture method, backed or backed alert colorimetry based, and backtech MGIT, Mycobacterium growth indicator tube that use fluorescence, fluorometric technology. These are drug sensitivity tests in a conventional method. This is the only 3 method that is used for drug sensitivity test in absolute concentration method, resistance ratio method, 1% proportion method. So these are the 3 conventional drug testing method, not the molecular. Conventional drug testing, resistance method, absolute concentration method, resistance ratio method, proportional method. Disadvantage: time taken for growth to occur before reading can be taken. So turnaround time is very high, at least 2 to 3 weeks. These are the few automated systems. PCR and ligase chain reaction, Gene Expert, TrueNat, transcription mediated amplification, line probe assay. What is the advantage of line probe assay? LPA is very important. Before only 1 to 2 years back, Gene Expert can only diagnose resistance to rifampicin. No other drugs can be tested for resistance in Gene Expert. Nowadays they have come up with other cartridges, but line probe assay is the molecular diagnostic test for choice for diagnosing the resistance in second line drugs also. Line probe assay is the method of choice for diagnosing, molecular method of choice for diagnosing the drug sensitivity or drug resistance. So remember line probe assay. Molecular typing, either based on DNA fingerprinting, IS 6110. Immunodiagnosis, already I have discussed about the PPD tuberculin test and IGRA. In duration 10 millimeter more, that is positive. In duration 5 millimeter or less, that is negative. 6 to 9 millimeter is equivalent in Mantoux test. So what is the interpretation? Positive Mantoux test. Infection or prior immunization with BCG, test become positive with 4 to 6 weeks after infection, wanes gradually and disappear after 4 to 5 years. Negative means he had no contact with tuberculous bacilli previously. What are the false negative tests? False negative Mantoux test. Sometimes even if the patient is having tuberculosis, false negative Mantoux test appears. One is miliary tuberculosis, convalescence from some viral disease, lymphoreticular malignancy, sarcoidosis, severe malnutrition, immune suppressive therapy, impaired cell-mediated immunity, and gamma interferon assay. Another advantage of gamma interferon assay, it does not test positive after BCG vaccination. So exposure to tuberculous bacilli is must for IGRA, but in Mantoux, even after BCG, Mantoux will come positive. There is another, that is why IGRA is more specific. Extrapulmonary tuberculosis. What are the samples you will take? Urine, CSF, biopsy material, CSF from tubercular meningitis. There is a stump, spider web coagulum. That usually is, if you keep the CSF in a room temperature, that will fall a spider web, মাকড়সার জালের মতো একটা combination হয়. If you keep get a tuberculosis patient and CSF you keep in room temperature, that will form a, why spider web coagulum is formed? Rationality why it is formed? Because high level of protein is there in the tuberculosis, but even in bacterial meningitis, the protein concentration is increased and sugar is decreased. But in tubercular meningitis, protein concentration is so much increased that it can form the spider web coagulum. This is the newest diagnostic technique, whole genome sequencing. You just need not know the nits and bits of whole genome sequencing, just know the name, whole genome sequencing. You can a comprehensive review of the entire Mycobacterium tuberculosis genotype. This is the upcoming, this is not in the theory, not in the book. Computer-aided detection of chest radiogram. There is a software called CAD4TB, CAD4TB, which even can analyze chest X-ray and diagnose tuberculosis without any microbiology confirmation, suspected TB. So this is a software-based diagnosis of chest X-ray also. This is the upcoming test. This is not in the book. CAD4TB is a software version 6. Now, what is MDR-TB? There are three terms. Now, MDR-TB, pre-XDR-TB, XDR-TB. So, what is MDR-TB? Resistance to rifampicin and INH. That is MDR-TB. This will be asked. This will be asked in exam. MDR-TB, resistance to isoniazid and rifampicin. Pre-XDR. This is a new term. Pre-XDR and XDR has come in 2020-21. So this is pre-XDR, TB caused by Mycobacterium tuberculosis. It is MDR. Plus, what is resistant in pre-XDR? It is resistant to any fluoroquinolone. Previously, what was the definition of XDR? XDR was defined as MDR-TB plus fluoroquinolone plus any injectable anti-tubercular. That was the definition of XDR before 2021. Now, they has been divided into two, pre-XDR and XDR. Pre-XDR is MDR plus resistance to fluoroquinolone, because levofloxacin is used as an anti-tubercular drug. So, when it is pre-XDR, so another is XDR, that is resistant to fluoroquinolone, additional group A drug. Group A drug means drugs which are used in second line of tuberculosis treatment. Which are the group A drugs? Levofloxacin, moxifloxacin, bedaquiline and linezolid. These are the resistance of fluoroquinolone and also these linezolid, group A drug. What is the advantage? Pre-XDR and XDR-TB point to increasing progression to the severity of the disease and resistance to the drug. The pre-XDR term has been innovated. The new definition of pre-XDR and XDR-TB applied from January 2021. So it was not there, only XDR was there. If older examiners come, you can tell this is the what is XDR, MDR plus fluoroquinolone plus any injectable drug. But this is the new definition, pre-XDR and XDR. Now this is the treatment protocol. Have you read anti-tubercular drug in pharmacology? Not yet. So what is the common drug, common for drug sensitive TB, which is not resistant to anybody? What is the duration of treatment? It is written 6 months. See, drug sensitive TB, resistant to no drug, rifampicin sensitive in CBNAT, that is 2-HREZ, INH, rifampicin, ethambutol and pyrazinamide for 2 months, followed by 4 months of INH, rifampicin and ethambutol. Now, what are the side effects? If you prescribe a patient antitubercular drug, what will be the common side effect for this drug? Rifampicin, you will get high colored urine or red colored urine. That is due to metabolite of rifampicin. Should you stop rifampicin for red urine? No. Next, pyrazinamide can do hepatitis. All drugs can do nausea, vomiting. So, first 2 drugs will be, first 2 months, HREZ, that is INH, rifampicin, ethambutol, pyrazinamide. Then 4 months for HRE, that is INH, rifampicin and ethambutol. What is the change? Previously it was 2 drugs in the last 4 months, now it is 3 drugs are used. This is the difference. Next, H mono or polyresin, that is only INH resistant. How will you know the resistant pattern in which INH in which gene is resistant pattern is? How will you know the resistant? It is the CAT-G gene. CAT-G gene for diagnostic of INH resistance. So where is that is the levofloxacin, rifampicin, ethionamide and pyrazinamide. That is 6 to 9 months. Then newer regime. This is H mono or polyregime for 6 to 9 months. That is levofloxacin along with rifampicin, ethambutol and pyrazinamide. Now these 2 shorter treatment, 2 newer treatment. What is the previous treatment for MDR TB? It was 6 months followed by 18 months. Now it has been shortened because use of the new drug bedaquiline. So now in National Tuberculosis Eradication Program, the drug that is used first is bedaquiline along with other drugs. So bedaquiline is a new drug for MDR TB. And what is the bedaquiline? Shorter regime, shorter bedaquiline regime for 9 to 11 months. And all oral longer MDR TB regime for 18 to 2 months. So duration of treatment is 9 to 11 months in case of shorter bedaquiline regime, and for longer regime 18 to 20 months. So levofloxacin, bedaquiline, ethionamide, clofazimine, pyrazinamide, INH and ethambutol is used for 5 months, followed by 6 months of levofloxacin, clofazimine, pyrazinamide and ethionamide. Next is all oral longer MDR TB, bedaquiline 18 to 20, total duration is 18 to 20 months, bedaquiline along with others for 6 months, followed by levofloxacin, linezolid, clofazimine and cycloserine. So these regime, at least if you don't remember all the regime, remember 2 regime. First is the 2 and 4 months for drug sensitive tuberculosis and drug resistant tuberculosis. What are the newer drug for? Because it is very difficult for your case to remember this shorter bedaquiline, but at least you tell the shorter bedaquiline course, bedaquiline with bedaquiline the name, and the longer bedaquiline oral course. There are some indication where you can have to use the longer course, not the shorter bedaquiline course for 9 to 11 months. So 2 HREZ and 4 HRE, that is 2 months of rifampicin, INH, ethambutol and pyrazinamide, followed by 4 months of INH, rifampicin and ethambutol. When you will use the longer oral bedaquiline containing regime, all MDR TB patients with no history of prior exposure to these drugs for 1 month or more, no previous exposure of drug, no resistance to fluoroquinolone, no extensive TB defining presentation such as bilateral lung cavity, extensive parenchymal damage, miliary or meningeal or central nervous TB, children less than 5 years, pregnancy less than 32 weeks. These are contraindication for shorter bedaquiline therapy. So these are the part of this treatment algorithm, integrated diagnostic and programmatic management of drug-resistant tuberculosis. It already was severe experimental. Now, before we go to some MCQ, let us recapitulate what you do. What are the things you do for tuberculosis diagnosis? One is sample. What are the sample for pulmonary tuberculosis? Sputum. Urine. How much urine will take for tuberculosis diagnosis for renal TB? How we will instruct the tuberculosis patient for extra pulmonary tuberculosis, renal tuberculosis? Because there is tuberculosis bacilli is not regularly shed in the urine. So you have to take 3 morning sample with at least 500 ml of urine each. Not the only 10 to 15 ml. At least 500 ml of urine to be taken for testing of tuberculosis that need to be centrifuged, and the deposit should be tested for acid first stain. So 3 morning sample with at least 500 ml of urine is needed. Previously what it was taken, 24 hours urine sample for 3 days were taken. So 3 morning sample but not in a small quantity, because this shedding of tuberculosis bacilli is not regular in urine. It's often regularly not shed. Next is CSF. CSF you cannot take more than 1 to 2 ml. Then another thing is other external lymph node. Lymph node, how will you diagnose? You aspirate, either do an FNAC or biopsy, send the biopsy sample to CBNAT, because now all the extrapulmonary tuberculosis to be sent for CBNAT or molecular diagnosis. CSF, tuberculosis or other things to be sent for molecular diagnostic upfront, not for sputum, smear. Another way of diagnosing lymph node TB, what is the other method? You can get an histopathology picture. You can do an histopathology biopsy and pathology histopathology. What will you get in a tubercular lymph node or any tubercular lesion with biopsy? You get a giant cell granuloma. So that is another diagnostic method of a sputum. We either do Gill-Nielsen stain or fluorescent stain, and we look for the grading, and even after the diagnosing of sputum AFB positive, it will be sent for CBNAT for diagnosing of rifampicin resistance. Next, how long it will take for the patient to become non-infective? A drug sensitive TB, you have started drug, how long at least you will ask the family member or the person to be cautious? After how many days, how many weeks patient become non-infective? You need to tell the patient how long patient will remain infective. What is the duration? After starting anti-tubercular drug, you have diagnosed tuberculosis, you have started anti-tubercular drug, what will you give? Anybody? $14 days, at least 2 weeks is required for diagnosing anti-tubercular patient is non-infective. Now, cartridge-based nucleic acid amplification test. How it is done? Sputum is collected, liquefying solution is given with the cartridge. You need to add that liquefying sample directly to the material given for the testing, and you put the cartridge in the CBNAT machine and you read the result after 2 hours. So that is gene expert. There is a given a cartridge is you will given a material for reagent material where the thing DNA or those things will be given for PCR, because what is the test? CBNAT, what type of test is this? CBNAT I have not done slide. Will ask CBNAT is Curtis-based nucleic acid amplification test. It is a PCR. What type of PCR is this? What is simple PCR? What is multiplex PCR? Multiplex PCR means more than one gene is detected. So this is a nested PCR. One is, that is also the two things. One is detected is the identification of tuberculosis, and second part is identification of rifampicin. Other categories come where is detecting the second line drug resistance. So what you should remember, what is the turnaround time? Turnaround time is 2 hours. It is a nested real-time PCR. Nested means first it detects the tuberculosis, then it is also detects the RPOB gene. At least you remember 2 genes for resistance. One is for rifampicin. RPOB gene is used to detect the rifampicin resistance. CATG gene is used for detection of INH resistance. CATG gene for INH resistance and RPOB gene for detecting the rifampicin resistance. So that is done after resistance. Even if you get the first line resistance, what you should do? You should advise line probe assay. Line probe assay should detect the other drug resistant pattern. So what are the flow chart? Do a sputum examination and chest X-ray. If a patient comes fever and cough for 2 weeks, you go for chest X-ray. If it is suggestive lesion, there is a lesion in the upper lobe, or patient having other symptoms like weight loss, anorexia, these are other constitutional symptoms for tuberculosis, go for sputum examination and chest X-ray, followed by, if it is suggestive, if it is not also suggestive, go for sputum for acid fast bacilli. How many samples? 2 samples, 1 stat, 1 next morning. After sputum for AFB, if it detects sputum for AFB, it's well and good. Then you send for CBNAT to detect the rifampicin resistance, then start the drug. This is the one protocol. When the algorithm, some part algorithm is there, some complicated algorithm. So this is again smear positive but not chest X-ray not suggestive, smear negative, chest X-ray suggestive, smear negative, chest X-ray not suggestive. MTB, if it is detected or CBNAT, not result not available, then you do reef sensitive, microbiologically confident reef intermediate, repeat CBNAT. If it is not equivocal, it's not given or the resistant or not resistant, then go for repeat CBNAT. Reef resistant, refer management for reef resistant. Now, sometimes we do, why we do IGRA, not doing other TB tests? Patient having no other symptoms of tuberculosis, but sometimes in, now here colony, you look at the colony character of Lewinson-Jensen media. What would be the colony character? Rough, buff and tough colony. The colonies are buff colored, it is rough and tough to remove from the Lewinson-Jensen media. So this is the characteristic of tubercle colony in the Lewinson-Jensen media, rough, buff and tough colony. Remember, what is the colony in Lewinson-Jensen media? It takes at least 2 to 4 weeks to develop the colony, rough, buff and tough colony in Lewinson-Jensen media. And the left side media. Now, Lewinson-Jensen media, have you read in practical about the media already? What is the content of Lewinson-Jensen media? Why it looks green? What is the malachite green? So, what is the role of malachite green? Have we added malachite green only for the coloring the media? So it will be look good on green. What is the rationality of adding malachite green? and it is 2% malachite green. I am telling the 2%. Why we have added malachite green? What is the rationality of adding malachite green? As we have seen, sputum will contain other bacteria also. So malachite green making the media selective. It kills the other bacteria other than tuberculosis. That's why malachite green is added. Malachite green 2% is added. What other is the content of Lowenstein Jensen media? This is an egg-based media. This is a hen's egg. If you prepare 1 liter of Lowenstein Jensen media in a liquid, you have to add 20 hen's egg. So this is an egg-based media. Other mineral acids are those things are there. How will you sterilize or how will you solidify? In all other media, in McConkey, nutrient agar, what is done for sterilization? It is given in autoclave. So how will you? What is the method of sterilizing or what is the method of solidifying? Usually all the media are prepared in liquid form. So how it solidifies? What is the solidifying agent? How it solidifies? In nutrient agar or McConkey or blood agar, agar is the solidifying agent. For 2% agar is added. Now what is the solidifying agent in Lowenstein Jensen media? Egg is the solidifying agent. Egg is added for the one of the nutrition and the second is solidifying agent. And how it is solidified, how it is sterilized? It is inspissated at 77 degrees centigrade for consecutive 3 days, for 1 hour for consecutive 3 days. So Lowenstein Jensen media, mineral acid, eggs and the malachite green is added. Egg is a solidifying agent and it is not autoclave. Autoclave, that initial part can be autoclave, but after adding egg or malachite green, it is usually inspissated. Inspissated for 1 hour daily for consecutive 3 days to make the media solid. And what is the colony character? Because rough, buff and tough colony, and you need to do the acid first stain again to confirm it is acid first bacilli. Middlebrooks media is mainly used for backtake MGIT tube. What is the liquid culture media? What is the advantage? Turnaround time is less. It can come in 2 weeks or 20 days, 2 weeks or 3 weeks, it can come positive. How it look like in a liquid media? When you see in an inverted microscope, serpentine cord-like character will appear. Just remember the serpentine cord-like in liquid media when you see in an inverted microscope in liquid media. This is not automated. Manual liquid media, when you not using any automated machine, serpentine cord-like structure will appear and that can be seen in an inverted microscope. Next is MGIT. These are back-tailored and backtake MGIT. These are the two automated liquid culture media. What is backtake and colorimetry based? And backtake MGIT, which is commonly used. How it gives fluorescence. So why it is not giving fluorescence? Because usually oxygen quenches the fluorescence activity. When the oxygen is there in the media, it will not fluoresce. But when oxygen is decreased and carbon dioxide, when microbacteria grows, it consumes the oxygen and carbon dioxide is liberated. That's why the quenching effect of oxygen is lost and there will be fluorescence. That is the principles of backtake MGIT. This can be asked. Backtake MGIT, liquid media, what is the principle? Again, drug sensitivity test, these are still it is going on. Even with CBDAT in the nodal centers, these are the 3 methods used for drug sensitivity. Even it has come in the MCQ this year for your final exam. The proportion method, 1% proportion method, absolute concentration method. Gene expert I have already discussed. This I have already discussed. whole genome sequencing. This is also pre-DR, MDR. Now, few MCQ. Symptom of question, can you see? It's very small. So, okay, later you can come to me. I will give this printout for few MCQs in the Mycobacterium tuberculosis. And then you do the MCQ and give me the answers. So I am not telling the answers now. You can take this part and print out. I will. You can, when you go for practical, anyone will take it from Raja. Okay, these two-part MCQ and then answer. Okay, any question from your side?
Coming to our discussion topic, we have to know what are the possible intracellular accumulation. So, the accumulation which is few cases normal or in few cases abnormal. So, intracellular means the accumulation which occurs inside the cell membrane. Okay. So, intracellular accumulation is invariably the manifestation of metabolic dearrangement. Okay. Accumulation may be transient and reversible or permanent. Effects are harmless to toxic. And there are three categories of intracellular accumulation. First, that is the byproduct of normal cellular metabolism. Next, accumulation of abnormal substances of abnormal cell metabolism. And third, and the last is accumulation of pigment. So, a cell is thrive to cellular metabolism for its own survival and for the survival of the tissue. So, accumulation of normal cellular metabolism comprised of three categories, namely protein, fats and carbohydrate. Okay? And the accumulation of abnormal substances of abnormal cell metabolism are namely the defect in scaffolding action or the transport of protein action defect of endoplasmic reticulum. So, namely the storage diseases and the inborn error of metabolism are categorized in the intracellular accumulation of abnormal cellular metabolism. Okay? And the thirds are accumulation of pigments. The pigments are of two types. One is endogenous pigment, that the pigments derived from our own body, and the exogenous pigment, or namely the tattoo. Okay? So, coming to the intracellular accumulation, namely there are four types: lipids, proteins, glycogens and pigments. The most common is lipids, accumulation of intracellular lipid. That is the most common scenario in our everyday practice. Okay? The accumulation of lipid is known as steatosis. Okay? And it occurs in various organs. Steatosis is accumulation of fat, accumulation of cholesterol and cholesterol ester. Accumulation of protein and glycogen are also present, but in lesser preponderance, and accumulation of pigment is also less common than accumulation of fat. So, accumulation of fat or cholesterol ester is the most common intracellular accumulation derived from normal cell metabolism. Now, mechanism of intracellular accumulation. First is abnormal metabolism, alteration in protein folding and transport by endoplasmic reticulum, deficiency of critical enzymes as depicted in glucosidase, as depicted in other enzymes which are categorically classified in common name as inborn error of metabolism. And the last is inability to degrade phagocytosed particle. So these are the possible mechanism of intracellular accumulation. Abnormal metabolism, alteration in protein folding and transport, deficiency of critical enzymes, and inability to degrade phagocytosed particle or phagolysosome accumulation. Now, coming to the most common portion, fatty changes or steatosis, fatty metamorphosis, intracellular accumulation of neutral fat or triglyceride within the parenchymal cells. This is more common in liver, okay? So, liver is our metabolic factory, the powerhouse of our body, and it is involved in innumerous numbers of cellular metabolism. So, liver is the most common site of intracellular accumulation of lipid or free cholesterol or triglyceride ester. So, this is called as steatosis or hepatic steatosis. But it can also occur in heart and large vessels, coronary vessel, namely as atherosclerosis, okay? And skeletal muscle and also kidneys. But most common and most predominant pattern of lipid accumulation is steatosis of liver, okay? So accumulation is in liver is most common entity. Causes of fatty liver, chronic alcohol abuse, very dangerous. So if a person is chronically addicted to alcohol, he or she may eventually develop alcoholic fatty liver or alcoholic steatosis in subsequent time. Obesity is another important cause because obesity is a condition which a person has excess body fat. Excess body fat may be deposited in skin, subcutaneous tissue, in gut, and also in solid organs like liver, also in blood vessels of heart and other critical organs like brain. So, protein malnutrition, starvation, suffering or death caused by lack of food, drugs and toxin, various drugs and toxin, namely anti-epileptic drug, phenobarbital, okay, valproate, these are carbamazepine, these are known to have deleterious effect of alcoholic hepatic steatosis, okay, anoxia and pregnancy. So pregnancy related alcoholic fatty changes, pregnancy related hepatic steatosis is also important factor and one of the important cause in pregnant females. So, but most common is alcohol abuse or chronic alcohol dependence. Now, this is a cut surface of which organ? Liver. So, this is a gross appearance when the alcoholic steatosis or fatty liver occurs in liver parenchyma. So, on cut surface, it has a smooth glistering surface, okay? And cut surface is shiny, greasy and yellow, okay? This is liver cut surface. So, this is shiny, okay? But the cut surface is smooth. But in case of cirrhosis of liver, we can see in your specimen of liver, long question, cirrhosis of liver, the appearance of liver is nodular, irregular, okay? But in case of fatty liver changes or alcoholic steatosis, the cut surface of liver, how does it look? Smooth surfaced, okay? Cut surface is greasy yellow and surface is regular. No irregularity or no nodularity is seen in early stages of alcoholic steatosis, okay? Now, other lipid accumulation, namely I told you atherosclerosis, xanthoma, okay? These are the other manifestation of lipid accumulation inside our body. In atherosclerosis, what does it occur? Cholesterol accumulates in the innermost layer, that is intima. So artery has three layers. One is adventitia, next is tunica media or muscular layer, smooth muscle layer, and the endothelial layer is intima. So the intracellular accumulation of fat has a tendency to deposit in the intimal layer or the endothelial layer. So this is called as atherosclerosis, and the cholesterol accumulates in smooth muscle cells and macrophages in the intima of the artery. And in hereditary hyperlipemia, cholesterol accumulates in macrophages, skin. We have macrophages, tissue macrophages, that is present inside our skin and subcutaneous tissue. Those are commonly named as APC, antigen presenting cells, or histiocytes. So these are basically specialized macrophage, and this macrophage sends the lipid or cholesterol ester as foreign body. They take up the cholesterol and the fatty material and form as foamy histiocytes. Okay, formation of foamy histiocytes, formation occurs inside the skin and subcutaneous tissue, that is known as xanthoma. So coming to the picture, atherosclerosis, common causes of many disease, xanthoma less common, and cholesterosis is accumulation of foam cell like cholesterol in gut and gallbladder. Okay, so atherosclerosis occurs in artery, intimal layer of artery. Xanthoma occur in skin and subcutaneous tissue, and cholesterosis occur in gallbladder. So why the gallbladder? Because gallbladder has a very important role in fat metabolism. Taito? So this is a normal artery, adventitial layer, medial layer, and intimal layer. Tear in the arterial wall by free radical injury or any break, okay, minor damage to the intimal wall, and fatty material deposited in the vessel wall. So the lumen got narrower, okay, due to deposition of fatty material inside the vessel wall in the intimal layer. And whenever the artery lumen or artery caliber is narrowed down, then what does it occur in the next step? The next step occur following the accumulation of fat in intimal layer is stasis of the blood. Okay, the blood which has been designed to flow in the blood vessel lumen in a larger speed or in a more speed, but with accumulation of fat, the intimal layer, the lumen of the artery got narrowed down, and it means the stasis of the blood, the flow of the blood is slowed down, and with the slowing of the blood flow along with the intimal break and the free radical injury, the platelet thrombi are begin to accumulate in the intimal layer, and there is formation of thrombi. Okay, so narrowed artery becomes blocked by a blood clot. This is known as atherosclerosis. And if this thrombus, any part of the thrombus is dislodged by the blood flow and settled to another distal location, what does it call? Emboli. Okay, very good. So this is a gross appearance of xanthoma, and this is the microscopic appearance of xanthoma. Subcutaneous tissue, we can see the yellowish tinge and the nodularity. You can appreciate that. Okay, knobby appearance. So this is a clue that a patient may have defect in lipid metabolism. And the lipid accumulation in the dermis, how does it look under the microscope? This is. So these are the cells, okay, these are the foamy cells, foamy histiocytes. This is the nucleus of the cell, and in the cytoplasm, what is cytoplasm? There are foamy appearance and accumulation of the lipid. So in xanthoma, we can get histopathological examination or biopsy picture like this, where accumulation of foamy histiocytes in the subcutaneous tissue and dermis. Okay? Clear everybody? So, another next important picture is cholesterosis. We can see the foamy histiocytes, okay, in high power. See, this is the nucleus of the cell and this is the cytoplasm, and this cytoplasm is carrying lipid. Okay, the cytoplasm, this is the cytoplasm, this is the cytoplasm, these are the cytoplasm. Okay, so this cytoplasm has foamy appearance. Okay, this is the epithelial tissue. This is a picture of gallbladder, cholesterosis of gallbladder, and this is the accumulation of foamy histiocytes. This is nothing but the specialized macrophage in the tissue. They take up the fat cell and formation of foamy histiocytes occur. Okay, everybody can see this picture from the last row. দেখতে পাচ্ছিস তোরা? এটা নিউক্লিয়াস সেলের, আর এই যে সেলের নিউক্লিয়াস গুলো ডটেড, ওকে, ডটস, blue dots are nucleus and the cytoplasm are foamy and containing lipids. So this is called cholesterosis. Okay, now coming to the intracellular protein accumulation. I told you that intracellular protein accumulation, they may be result of excessive amount of normal proteins and defective intracellular transport and secretion of proteins. So excessive amount of normal proteins are mainly seen in multiple myeloma as Russell body. So what does the multiple myeloma disease does to our body? That is increased uncontrolled monoclonal proliferation and production of immunoglobulin secreting cells. Okay, what cells secrete immunoglobulin? B cells, plasma cells. ঠিক আছে, plasma cells. So in multiple myeloma there are monoclonal proliferation or the unput downable proliferation and production of immunoglobulin. So from the increased amount of plasma cells in our body. So the excessive amount of immunoglobulin is deposited as a cytoplasmic globules, namely commonly known as Russell body. Okay, so I will show you the pictures in later. And another intracellular protein accumulation defect is intracellular transport and secretion of protein due to mutation in which gene? CFTR gene, chromosome 7, right? Cystic fibrosis. So defective intracellular transport and secretion of protein and accumulation of mucin in airway and in lungs. So the patient will suffer from tachypnea, dyspnea and difficulty of breathing, and unfortunate kids are very small lifespan. They may not cross their second decade of their life. Hi Nana একটা সিনেমা দেখেছিস কেউ নেটফ্লিক্সে? হাই নানা না হাই পাপা? হাই পাপা, নানি আছে, সাউথ ইন্ডিয়ান. There's movie involve a small child, a girl child who has CFTR gene mutation or cystic fibrosis. So this is a very dangerous. So all the diseases which encompasses the defective cellular metabolism or deficiency of any enzymes are mostly autosomal recessive. Okay, and the diseases of defect in structural proteins are mostly autosomal dominant. So this is cystic fibrosis is a intracellular accumulation of abnormal protein and it is a autosomal recessive type of disorder. So defect in protein folding, defect in intracellular transport and secretion, endoplasmic reticular stress induced by unfolded and misfolded protein and accumulation of endoplasmic reticulum. So ER stress, a short note, very important. Okay, so ER stress is main thing to cause intracellular accumulation of protein, aggregation of abnormal and misfolded proteins in tissue in cystic fibrosis. So this is amyloidosis picture. Okay, tongue and subcutaneous tissue. This is also an example of abnormal protein accumulation in skin and subcutaneous tissue and mucous membrane. Okay, round eosinophilic droplets, vacuoles or aggregates in cytoplasm may be amorphous or crystalline. Example is amyloidosis. So there are many diseases. You need to just know the examples and the defects, whether the protein folding defect, whether the ER stress defect, whether the transport of the protein defect, whether any enzyme defect. Okay, so this is an example of intracellular protein accumulation or accumulation of abnormal protein, namely amyloidosis. Amyloidosis is a very important topic for your professional examination and internal assessment examination. It will be taught later. Okay, now excessive normal proteins or immunoglobulin. This is Russell body. Okay, this is plasma cell. Okay, normal plasma cell, B cell or plasma cell. Okay, eccentric nucleus, cytoplasm, moderate amount of cytoplasm, অনেকটা ডিমের মতো দেখতে, ovoid shape, but this is Russell body. Okay, so immunoglobulin are deposited inside the cell in cytoplasm and abnormal production of the normal protein or immunoglobulin. So this is a picture of Russell body. Okay, everybody can see this picture. So this is Russell body, this is plasma cell. Okay, now the cut surface of the lungs affected by cystic fibrosis. You can see the mucin plugs entangled over here. Okay, this is trachea, this is two lungs. Okay, tracheobronchial tree, and you can see the whitish, thick, tenacious mucus. Okay, whenever the mucus is more thick, the mucus is very hard to expel, and now when the mucus is thinner, the mucus is easy to expel. So in cystic fibrosis, due to defect in CFTR gene, the defect in enzyme alpha 1. Which enzyme? Alpha 1 antitrypsin. আচ্ছা তো তাহলে এনজাইম ডিফেক্টের জন্য মিউকাস ক্লিয়ারেন্স হয় না, and these mucus are clogged within the tracheobronchial tree. Now intracellular accumulation of glycogen, abnormal metabolism of glucose and glycogen result in excessive intracellular accumulation in uncontrolled diabetes mellitus. Okay, so the carbohydrate metabolism whenever altered, the most important disease in our common practice of defective carbohydrate metabolism is diabetes mellitus. Sugar বলা যাবে না পরীক্ষায়, diabetes mellitus. Okay, so in diabetes mellitus, abnormal carbohydrate metabolism occurs and intracellular accumulation of glycogen occur in liver, in kidney, okay, in blood vessels, everywhere in the body, like macroangiopathic effect, microangiopathic effect, সব এগুলো পরে পড়াবে. So coming to the last, intracellular accumulation of pigments. So what are the pigments? Endogenous pigments and exogenous pigments. Endogenous pigments are lipofuscin, melanin. Very good. Most important endogenous pigment is melanin, and melanin is a pigment. How does it form? Melanogenesis, from the knowledge of biochemistry. Amino acid. Which amino acid? Tyrosine. So pigments can be exogenous or endogenous. So endogenous pigment list, melanin, most important, melanin like pigment deposition in diseases like alkaptonuria, Dubin-Johnson syndrome in liver, hemoprotein derived pigments, hemosiderin, okay, acid hematin or hemojoin, bilirubin, another hemoglobin byproduct, bilirubin, porphyrin, and lipofuscin, that is wear and tear pigment. Very important for short note, lipofuscin, okay, wear and tear pigment. And from the exogenous pigments are inhaled pigment and injected pigment, okay. But most important is melanin. And exogenous pigments are inhaled due to inoculation by injection or by ingestion. In case of coal worker, mine worker, those have high, those who have tendency and have to work in highly polluted areas where the very particular amount of coal is present in atmosphere. So exogenous pigments are carbon, anthracosis, accumulation of carbon in lung, coal dust, pneumoconiosis, okay, lung pick up by the alveolar macrophage and regional lymph node and blackening of the tissue of the lung, that is anthracosis. So the people or the coal miner, those who work in coal or in mine, have contact with coal or anthracites in their lifetime, they have a tendency to develop invariably anthracosis in their lungs. So the lungs, alveolar macrophage take the pigment and the lungs take a color of black lung. So this is a picture of lung. Okay, you can see the black pigment over here inside the lobe, inside the alveolus. The black streaks seen between the lobules of the lung beneath the pleural surface are due to accumulation of anthracotic pigments. দেখতে পাচ্ছি সবাই? So this is the gross appearance of the lungs. The black streaks are mostly due to accumulation of coal or anthracosis, okay? And whenever we have chance to dissect it and make it a slide from the tissue, the slide looks like this way. Anthracotic pigment, these are nothing but the alveolar macrophages taking up the black pigment coming from the coal, okay? দেখতে পাচ্ছিস এই যে pigments গুলো, these are cytoplasmic pigment, intracellular accumulation of pigments, anthracotic pigment in macrophages in hilar lymph node. যখন লিপিড জমেছিল সেলে তখন কি দেখিয়েছিলাম? ফোমি হিস্টিওসাইটস, তাই তো? সাইটোপ্লাজম গুলো ফোমি ছিল, কোলেস্টেরল নিয়ে নিয়েছিল, আর এখানে ম্যাক্রোফাজ গুলো কি নিয়ে নিয়েছে? ব্ল্যাক পিগমেন্টস, তাই তো? অ্যান্থ্রাকোটিক পিগমেন্ট. সো আওয়ার policeman of the tissue is macrophage. Whenever any foreign body are encountered by the macrophage has a large shape of cytoplasm and a pseudopodia-like action. So any foreign body, they are taken up by the macrophage, and the macrophage, they alter their cytoplasmic texture according to the nature of foreign body or nature of the accumulation or nature of the pigment, okay? So anthracotic pigment are seen all over the cytoplasms of the cells, okay? These are the nucleus, alveolar macrophage, and these are the anthracotic pigment deposited in alveolar macrophage cytoplasm. দেখতে পেয়েছি সবাই? Everybody from the last row? Here, tattoo man. Injected pigments or tattooing. Pigments like India ink, cinnabar, carbon are introduced in the dermis in the process of tattooing, where the pigment is taken by the, again, the pigment is taken by the macrophages, okay? Histiocytes or the antigen presenting cell. There are many names of macrophage and lies permanently in the connective tissue. The examples are injected pigments are prolonged use of ointments containing mercury and tattooing by pricking the skin with dyes. Anybody have tattoo? In the class? No one? Acha. So this is a classic example of exogenous pigment and very common nowadays in player, in film star. Okay, they are fond of tattooing. Now the wear and tear pigment, lipofuscin. কি হয়েছে হাসছিস কেন কার ট্যাটু আছে লুকিয়ে রেখেছে কে তোর দেখা দেখানোর জায়গায় আছে use of liposomal digestion. So this is wear and tear pigment. Okay, lipofuscin comes from the abnormal lipid metabolism. Okay, liposomal digestion found in liver, kidney, heart muscle, retina, adrenals, nerve cell and ganglion cell. But most common deposition of lipofuscin is site is liver. Okay, so this is the cardiac muscle lipofuscin. এই যে pigment, golden yellow pigment, abnormal liposomal digestion. দেখতে পাচ্ছিস তো গোল্ডেন ইয়েলো পিগমেন্ট, এটা কার্ডিয়াক মায়োসাইট দেখ, কার্ডিয়াক সেল স্পেশাল মাল্টিনিউক্লিয়েটেড সেলস, এ দেখ দুটো নিউক্লিয়াস আর হচ্ছে গোল্ডেন ইয়েলো ব্রাউন পিগমেন্ট. দিস ইজ ওয়্যার এন্ড টিয়ার পিগমেন্ট. এই দেখ ওয়্যার এন্ড টিয়ার পিগমেন্ট ইন হেপাটোসাইটস, যে এগুলো হচ্ছে হেপাটোসাইটস, নিউক্লিয়াস অফ দ্য হেপাটোসাইটস, আর এগুলো হচ্ছে গোল্ডেন ইয়েলো পিগমেন্ট লাইপোফুসচিন. দেখা যাচ্ছে ছবি সবার? So this is lipofuscin in hepatocytes. Now coming to the melanin, the most common endogenous pigment, the pigment that gives human skin, hair and eyes their color. Melanin is produced by the cells called melanocytes. Okay, amino acid tyrosine is followed by polymerization and multi-stage chemical procedure of formation of melanin, that is called melanogenesis. So disorder of melanin pigmentation, whether melanin are present in abundance or the melanin are present in scarce. So if the melanin is present in abundance, that is called hyperpigmentation, and if the melanin are scarce in our body, less produced than required, then it is called hypopigmentation. So hyperpigmentation, there are examples of generalized hyperpigmentation and localized hyperpigmentation. Among the generalized hyperpigmentation, the disease are Addison's disease and colasma. Okay, metabolic disease due to overproduction of mineralocorticoid. Okay, so tendency of hyperpigmentation all over the body. This is colasma, are common in the female who are taking OCP, oral contraceptive pill for birth control measure, are prone to develop colasma in their skin and subcutaneous tissue in later half or to third to fourth decade of their life after prolonged ingestion of oral contraceptive pills. Okay, তাহলে generalized হচ্ছে Addison's disease and colasma, আর localized Pew-Jeghers syndrome and melanosis coli. This is colon and formation of blackish patch in colon, and Pew-Jeghers syndrome is formation of subcutaneous blackish pigmentation in skin and mucous membrane. So generalized example of hyperpigmentation, Addison's disease and colasma, and localized example of hyperpigmentation is Pew-Jeghers syndrome and melanosis coli. Okay, next hypopigmentation. Generalized hypopigmentation is called as albinism. Okay, and localized form is known as vitiligo. So these two diseases or these two entities are caused due to less production of melanin. Very good. Now hemosiderin, another endogenous pigment. Okay, hemosiderin. Hemosiderin is mainly involved in storage and transport of iron. Okay, so hemoglobin derived golden yellow to brown granular or crystalline pigment, major storage form of iron. Hemosiderin is an iron storage complex denatured ferritin and other material, the iron within deposits hemosiderin is very poorly available to supply iron when needed. So, hemosiderin pigmentation occurs in the patient of thalassemia. Okay, thalassemia patient or chronic hemolytic patient, they have an urgency to multiple episodes of blood transfusion in their lifetime. So, with every blood transfusion episode, every time the iron load in our body will be increased. So, after an episode of 15 to 18 years, okay, these diseases like major chronic hemolytic anemia, thalassemia, those patients who have received frequent blood transfusion are prone to develop hemosiderin deposition in their liver. Okay? So, this endogenous pigment, iron pigment, appears as coarse golden granular pigment lying within the cell cytoplasm. এগুলো হচ্ছে এটা liver. So, liver is the main thing, main powerhouse or factory, metabolic factory of our body. So, any pigment has the most affinity to deposit in liver for our own homeostasis purpose. যতক্ষণ লিভার টেক আপ করতে পারছে ততক্ষণ ও আমাকে বেশি অসুবিধা করবে না। যখন লিভারের ক্যাপাসিটি আস্তে আস্তে রিভার্সিবল থেকে ইরিভার্সিবলের দিকে চলে যাবে তখন আমার সমস্যাগুলো শুরু হবে। ঠিক আছে, তাহলে দিজ আর হেপাটোসাইটস, নিউক্লিয়াস অফ দ্য হেপাটোসাইটস and the cytoplasm are loaded with iron pigment, appears as coarse golden granular pigment lying within the cell cytoplasm. এই যে granular pigment, coarse pigment দেখতে পাচ্ছিস সবাই? So this is hemosiderin laden macrophages. Okay, very common in patients of কি বললাম thalassemia. ঠিক আছে, ওদের আয়রন প্রোফাইল রেজড হবে, বিলিরুবিন রেজড হবে। কেন? লিভার ফাংশন আস্তে আস্তে নষ্ট হয়ে যায়। ফর রিপিটেড ব্লাড ট্রান্সফিউশন, আয়রন ওভারলোড, পড়তে হবে এগুলো সব পড়াবে। সো থ্যাংক ইউ।
সো একটা টেবলে এরকম কোয়েশ্চেন থাকবে, দেয়ার উইল বি ওয়ান, দ্য কোয়েশ্চেন উইল বি লাইক দিস, from this plate estimate the age and write the medical legal opinions or about this means about this topic. About this topic বলতে একটা প্রত্যেকটা টেবলে এক একটা আইটেম থাকবে। সো একটা টেবলে হয়তো স্কাল থাকলো, ওটা বোনসের, একটাতে থাকলো এক্সরে যেটা এটা, আর একটা থাকবে পয়জন। ঠিক আছে, আইডেন্টিফাই দি পয়জন অ্যান্ড রাইট মেডিকো লিগাল অ্যাসপেক্টস অ্যাবাউট ইট এরকম। তারপরে থাকবে হচ্ছে ওয়েপন। এইগুলোই বেসিক্যালি প্র্যাকটিক্যাল এক্সামে আসে সব জায়গায়, যে কোনো কলেজেই এই সেম জিনিস হয়। তো ওটার একটা পার্ট প্র্যাকটিক্যালের। সো এরকম একটা স্লাইড দেওয়া থাকবে, এক্সরে আলাদা আলাদা, নট দিস সেম স্লাইড উইল বি গিভেন টু ইউ এভরি টাইম। সো উইল চেঞ্জ দি slides also, এক্সরে প্লেট। ওকে, সো দি ফার্স্ট thing you have to write is what is this. ঠিক আছে, so as you get the x-ray you have to write what is this. What is this? The examiner will also be asking the same question, what is this? So you have to answer in a scientific way. So what would be the answer? The answer should be like this. So write it down. It is a sciagram of whichever it may be, এই যে L আর R, ঠিক আছে, এল মানে লেফট হ্যান্ড, আর মানে রাইট হ্যান্ড। ঠিক আছে, তো সেই হিসেবে তোমরা বুঝতে পারবে যে ওটা লেফট হ্যান্ডের এক্সরে না রাইট হ্যান্ডের, আদারওয়াইজ ইউ কান্ট। ওকে, সো ইট ইজ এ স্কায়াগ্রাম অফ লেফট অর রাইট এলবো জয়েন্ট ইন উইচ ভিউ। এটা হচ্ছে অ্যান্টিরিয়র পোস্টিরিয়র ভিউ, ল্যাটারাল ভিউ হতে পারে, and another one is oblique view. So oblique view is not needed here. We need anterior posterior and lateral view, anterior posterior and lateral view. So in case of age estimation also, we normally for elbow joint we prescribe anterior posterior or and lateral view. ঠিক আছে, সো এরকম ভাবে এটা লেখা হয়ে গেছে। this you have to write in, this answer you have to write in exam also. এক্সামে যে যখন ওই টপিকটা মানে আইটেমটা আসবে ওই আইটেমটাকে এইভাবে আমাদের রিপ্লাই করতে হবে। কি কি বোন আছে যেটা আমরা দেখতে, হোয়াট এভার দি বোনস উই আর ভিউইং ইট, উই হ্যাভ টু রাইট ইট ডাউন, লাইক শোয়িং আপার অ্যান্ড লোয়ার এন্ড অফ হিউমারাস, ঠিক আছে, ওইভাবে রেডিয়াস অ্যানাল না, এইভাবে এইগুলো মেনশন করতে হবে। যদি রিস্ট জয়েন্ট আসে তাহলে কার্পাল বোনস, তারপরে ডিস্টাল এন্ড অফ রেডিয়াস, ডিস্টাল এন্ড অফ আলনা, ওগুলো মেনশন করতে হবে। রিস্ট জয়েন্টের জন্য আলাদা একটা ক্লাস হবে, এটা এলবো জয়েন্টের জন্য, বিকজ বেসিক্যালি ইন এক্সামস we will be providing you elbow joint, wrist joint and pelvis chiefly, because those items means those are the prominent things that we can guess the age from, ঠিক আছে। তাহলে এটা লেখা হয়ে গেছে, এরপরে এটা লেখো, এইটা লিখে নাও। एक्सरे फाइंडिंग से एक्सरे ऑफ एल्बो जॉइंटे की लागे हमारे मीडियल एपिकॉन्डाइल, लैटरल एपिकॉन्डाइल, ओलेक्रोनॉन टिप प्रोसेस और रेडियल हेड, ठीक है। एगुलो लेखो और ओखाने पाशे लिखबे অ্যাপিয়ার্ড, নট অ্যাপিয়ার্ড, ফিউজড, নট ফিউজড, এইভাবে। So this thing should be correlated with the chart. On the right hand side you can see that is gallstone chart. Gallstone chart is important because it is for the Bengali population. Gallstone chart, Galstaun, Gallstone chart. So Gallstone did the study of Bengali population, on Bengali population, and got the parameters, means he got, which means by the data from that study, that when fusion happens, when appearance happen in Bengali population, ठीक है, Gallstone, he did this study on, and it is accepted by High Court, Calcutta High Court. That is why the chart is important. So every state may have different charts according to their population. So for West Bengal, Gallstone chart is accepted. As we are in West Bengal, we will follow this. So from this we will determine the age, okay, because the X-ray plate that will be provided to you will be from this, our means Bengali population, our college only. The plates will be provided to you. So we have to, how to interpret this chart, I will tell you. You have noted this down, right? So next thing you have to note is this one, opinion, the third part, opinion, eta lekho. So the X-ray has to be, in exam, has to be interpreted in three parts. First is, what is this? You have to identify this slide. Then is the body part, that is that appeared or not appeared, and the third is the opinion part. So you write it down as it is, as it is. In exam also you just have to write as it is, only the values will change as per your what do you call, as per your interpretation. We cannot give the age, exact age, like we cannot say he is 14 years old or he is 15 years old. We cannot say that. We have to give it in a range. So it is above and below. Above ato, below ato. we'll always give it in a range. Why so? Because in biology there is variation. So due to natural environment or climate, the pattern means the ossification age may vary from 1 or 2 years or more even sometimes. That's why. And this is for normal people. No, don't consider like abnormal people, those means having disease or something like that. Okay, for them this is not going to help. It is for in general population. Okay. So 3 parts. First is, what is this? Heading. What is this? You will write that one, what you have written. Then there is body part, what appeared, what not appeared, what fused, not fused. And the third is the opinion part. Okay, fine. So let's start with little bit of anatomy of the wrist joint. As you can see, distal end of humerus. What is this? Proximal end of ulna and radius. Okay, fine. What is this? Radius. So this side is what? Medial or lateral? Lateral. This side is medial. Okay, fine, clear. So CRITOE, this is a mnemonic. Okay, mnemonic to remember the age of appearance of ossification centers. C is for capitulum, R is for radial head, T is for trochlea, O is for olecranon process, and E is for external epicondyle. External means lateral epicondyle. I is internal epicondyle. Okay, internal epicondyle. This E is for external. Internal meaning medial side, and E means lateral side. Clear? So this is a mnemonic, nothing else. So in X-ray you can identify those things. Just above radial head is capitulum. Okay, just above radial head is capitulum. What is external? Lateral to it is what? Lateral epicondyle. Here trochlea. Above trochlea is olecranon process, and just medial to it is medial epicondyle or internal epicondyle. Okay, fine. So see the age of appearance. Okay, here first is C, capitulum. Capitulum appears at 1 year age of age. Here it is. Okay, capitulum. Then R is radial head, 4 to 5 years. Then what? Medial epicondyle, 4 to 5 years, almost similar. These values are almost similar. Then what? CRI, then T. T is for trochlea. Where is trochlea? Okay. Then O, olecranon process. Then E, external epicondyle, 10 years. Okay, this is the mnemonic to remember the appearance. Okay, so how will it appear in X-ray? Means this one, everything is fused. That's why you will not find that gap. Here you can see there is a gap, radial head. Okay, and these are the mnemonic. It's not important right now. We'll proceed further. So now coming to the gallstone chart, how to interpret. Okay, এখানে সব দেখতে পাচ্ছ, এটা কি হয়েছে? অ্যাপিয়ার হয়েছে, রেডিয়াল হেডে অ্যাপিয়ার হয়েছে না হয়নি? অ্যাপিয়ার্ড, নট অ্যাপিয়ার্ড? ossification center, appeared, not appeared? No idea. See, there is a gap, okay. So it has appeared but not fused. Appeared, not fused. Fine. What about this? Appeared, not fused. Where is the, what do you call it? Lateral epicondyle. Where is it? Appeared, not appeared? Not appeared. What about this? Medial epicondyle. Appeared, but not fused. Fine. So you can now interpret this X-ray. Now this should be compared with this chart. The above part is for elbow joint. Okay. Then comes wrist joint, that we will learn in another class. So in this class we will learn about elbow joint. Means this class is about elbow joint. You should be perfecting elbow joint in this class. So you have to know what things you will need for estimation of age. First is the medial epicondyle, lateral epicondyle, and tip of olecranon and radial head. These four things. From these four things we can estimate the age. We don't need trochlea and we don't need capitulum as per this chart. So only by this four value means parameters we can estimate the age. So for males it is different, little different. Female it is different. Females is just 2 years earlier, most values, and in males it will be 2 years later. Okay, that is mostly the difference. So can you is this numbers visible to you? Is visible? Or you can adjust yourself so that it becomes visible. Okay. So now try to estimate the age from this slide. That is your task. So that is the question that will come in exam. এই স্লাইড থেকে তোমরা এস্টিমেট করবে, ওপিনিয়ন যেটা আছে ফর্ম করো, ঠিক আছে? দিস উইল বি দি কোয়েশ্চেন. সো ফার্স্ট ইউ উইল রাইট দ্যাট পার্ট. Take a fresh page and just try to answer this question. What I have given you the first part, write it down. This is a, what is just the X-ray. What is this X-ray about? Take it as a test. You will start writing with the heading part first. Write it down. I will check. Ki likhcho. This is a, लिखेছো? लिखो फिर से अलग से अलग অন্য একটা পেজে. এটা you have to practice this a lot, otherwise you will not be able to answer in 10 minutes. In exam you will just get this item for only 10 minutes. That's why I am more emphasizing on the practically means teacher will, I will spoon feed you this part. So you have written heading part. This is an X-ray showing what, or this is anterior posterior view, this is lateral view. So do you know which hand? Right hand. What if I flip this X-ray? Then what? You won't know. Likha nahi. So while answering you will say assuming it as left hand. Assuming it as left hand. Whether it is female or male? Not written. So this type of question will be asked in your exam. They will be asking this of which hand is it? You won't have, if I have not told you right now that this sort of question will be asked, you will have not known. In exam you will sit what to answer. So this sort of questions will be asked. Next will be, if nothing is given left or right, assume it as left hand. Okay, left hand. And whether sex is not mentioned here, male female is not mentioned here, then also you will assume it as what? Female. Left hand female. Okay, fine. Assuming it as female. Okay. Then come ওটা লেখা হয়েছে ওপিনিয়নে, তাহলে ওটা লেখো. this is a skygram of left elbow in which view, anterior, posterior and lateral view, showing which bones, or copy it from the whatever you have written before. হয়েছে? See how difficult it becomes when you have to attend it in exam. So you need practice. It may seem easy, but it ain't easy. We have done this maybe 100 times or more. Still we have to refer and write when we have to submit it in before court. It should be accurate. ওকে, হলো? দেখে দেখে লেখা হলো? ঠিক আছে। এইবার সেকেন্ড পার্ট, ফাইন্ডিংস। এবার ফাইন্ডিংসে কি করে লিখতে হয়। ফার্স্ট মিডিয়াল এপিকন্ডাইল, ঠিক আছে? মিডিয়াল এপিকন্ডাইল কোথায় আছে? অ্যাপিয়ার্ড, not fused. So you write it down. Findings, then medial epicondyle, দিয়ে appeared, not fused. ঠিক আছে? Next parameter, lateral epicondyle, not appeared, bas not appeared, bas লিখো not appeared, fine. তারপরে কি আছে? টিপ অফ ওলেক্রানন প্রসেস আছে? নেই, নট অ্যাপিয়ার্ড, ঠিক আছে? আরেকটা কি আছে? রেডিয়াল হেড আছে? অ্যাপিয়ার্ড বাট নট ফিউজড। লেখা হলো প্যারামিটারগুলো, I've written down. Now interpret. So it was a female, right? As nothing has been mentioned over here. ফিমেলে প্রথম থেকে মিডিয়াল এপিকন্ডাইল কি লিখেছিলে? অ্যাপিয়ার্ড বাট নট ফিউজড। সো অ্যাপিয়ার্ড ইজ 5 years অ্যান্ড নট ফিউজড। 14 উইথ শাফট মিন্স above 5, below 14, মানে roughly. So just you say above 5 for now, above 5. তারপরে ল্যাটারাল এপিকন্ডাইল অ্যাপিয়ার হয়েছে? হয়নি, তাহলে বিলো 10 হয়ে গেল। অ্যাবভ 5, বিলো 10 আপাতত রাফলি। তাহলে তারপর তার থার্ড প্যারামিটার হচ্ছে টিপ অফ ওলেক্রানন প্রসেস, অ্যাপিয়ার হয়েছে? হয়নি। সো ইট বিকামস বিলো 9 to 12, ন্যারো হচ্ছে, আস্তে আস্তে নিচের দিকে যাচ্ছে। তারপরে রেডিয়াল হেড অ্যাপিয়ার হয়েছে 6 years, তাই তো? তাহলে above 6, below 9. Okay. লেটারাল এপিকন্ডাইল তো অ্যাপিয়ার করেনি, তাই তো? তাহলে অ্যাবভ 6, বিলো 10 কেন এবার বলছি? টিপ অফ ওলেক্রানন তো বলছে 9 to 12, 9 to 12 আছে, কিন্তু আমরা দেখব ওপরেরটা 12 আছে এখানে। 12 ইয়ার্সেও অ্যাপিয়ার করতে পারে, তাই তো? 12 ইয়ার্সেও অ্যাপিয়ার করতে পারে, বাট উই আর সার্টেন অ্যাট 10, 10টা এক্স্যাক্ট ভ্যালু হয়নি। সো অ্যাবভ 6, বিলো 10 হয়ে গেল আনসার। লেখো ওটা ওই ফরম্যাটে লেখো যেভাবে বলা হয়েছে ওপিনিয়নে। হ্যাঁ, এক্স-রে ওপিনিয়ন। সো ইন এক্সাম দিস চার্ট ওন্ট, হ্যাঁ এই চার্টটা মুখস্থ করতে হবে। ফরেন্সিকের এক্সামে তো এইটুকুই মুখস্থ করতে হবে, এইটুকু না, অনেক কিছু আছে মুখস্থ করার, বাট এটা পার্ট অফ ইট। সব জয়েন্ট বেশি নেই তো, এই ক্ল্যাভিকাল তোমাদের দেওয়া হবে না, এই এলবো জয়েন্ট একটা আছে, রিস্ট জয়েন্ট একটা আছে, আর কাউরি ভাগ্য খারাপ থাকলে তার পেলভিসটা পড়বে, ঠিক আছে, এই তিনটেই আছে, ঠিক আছে। Most probably we'll get these three only in exam also. No, no, no. We cannot differentiate the sex from X-rays. Mention, ওখানে যদি মেনশন করা থাকে ফিমেল লেখা থাকে এক্স-রে, then you can say it is of a female. If the information has been provided to you, then you know. From the information provided to me, you will say from that. From the information provided to me, you will answer like that, that it is of a female. But not by the X-ray. We cannot estimate the sex. Age can be estimated. Any fracture disease can be estimated. Okay. Holo? Opinion লিখেছো? So this is how you answer in exam also. Above 6 years and below 10 years. Radial head তো অ্যাপিয়ার করেছে, এই তো 6 ইয়ার্সে রেডিয়াল হেড, আর 5 ইয়ার্সে কোনটা ছিল? 5 ইয়ার্সে কি অ্যাপিয়ার করে? মিডিয়াল এপিকন্ডাইল। 5 ইয়ার্সে মিডিয়াল এপিকন্ডাইল, আর রেডিয়াল হেড হচ্ছে 6 ইয়ার্সে, তো দুটোই অ্যাপিয়ার করে গেছে, তাই তো। এটা 5 ইয়ার্সে হয়েছে, এটা 6 ইয়ার্সে হয়েছে, তো অ্যাবভ 6 ইয়ার্স। ফিউজ একটা হয়নি। Appearance age is more important than fusion age. Appearance is more important. Okay. Means যদি clash হয়, if there is a clash, means 50-50 chance আছে এটা হতে পারে ওটাও হতে পারে, we will take the appearance as means more important. আছে এখানে, it may be given to you, but in exam the age will be hidden. Okay. Name will be also hidden, so that you cannot guess whether it is a male or a female, unless and until only the sex has been mentioned. ঠিক আছে, this is of a elbow joint. So now, as I have showed you what parameters you have to see, and chart is over there. Now you have to write this down, means this is a test for you. এটা একদম ক্লিয়ার আছে, সেন্টার অ্যাপিয়ার করছে না করছে একদম ক্লিয়ার আছে। কোনটা? ওটা, that is because of how the technician performs the X-ray, মানে কতটা ওই কন্ট্রা এক্সপোজার করে ওটা ওরা কন্ট্রোল করে, সেটা সেই সময় হয়নি, বাট it is visible, it is very prominent. So as I have told you to interpret, now try to interpret within 15 minutes at least. You can discuss among yourself how to do it, but do it as it is, like the heading part, what is this, then the findings, and finally the opinion. So this, then you will be means what you call, you will get this age within 15 years. Means ওই প্যারামিটারসে ফেললেও তুমি দেখবে যে এটা 15 ইয়ার্সই আসছে, করো তাহলে বুঝতে পারবে যে এটা প্র্যাকটিক্যালি অ্যাপ্লিকেবল কিনা। এটা প্র্যাকটিক্যাল মানে এখানকারই, ঠিক আছে, এটা শান্তিনিকেতন মেডিকেল কলেজ হসপিটালে, ঠিক আছে। So you can have, take your seat, you can have a seat or whatever you feel comfortable, try to solve this one. Okay, লেখো সবাই একটা করে খাতা আছে এখানে, it may be given to you, but in exam the age will be hidden. Okay, name will be also hidden, so that you cannot guess whether it is a male or a female, unless and until only the sex has been mentioned. ঠিক আছে, this is of a elbow joint. So now, as I have showed you what parameters you have to see, and chart is over there. Now you have to write this down, means this is a test for you. এটা একদম ক্লিয়ার আছে, সেন্টার অ্যাপিয়ার করছে না করছে একদম ক্লিয়ার আছে। কোনটা? ওটা দ্যাট ইজ বিকজ অফ হাউ দি টেকনিশিয়ান পারফর্মস দি এক্স-রে, মানে কতটা ওই কন্ট্রা এক্সপোজার করে ওটা ওরা কন্ট্রোল করে, সেটা সেই সময় হয়নি, বাট ইট ইজ ভিজিবল, ইট ইজ ভেরি প্রমিনেন্ট. সো অ্যাজ আই হ্যাভ টোল্ড ইউ টু ইন্টারপ্রিট, নাও ট্রাই টু ইন্টারপ্রিট উইদিন 15 minutes at least. You can discuss among yourself how to do it, but do it as it is, like the heading part, what is this, then the findings, and finally the opinion. So this then you will be means what you call, you will get this age within 15 years. Means ওই প্যারামিটারসে ফেললেও তুমি দেখবে যে এটা 15 ইয়ার্সই আসছে, করো তাহলে বুঝতে পারবে যে এটা প্র্যাকটিক্যালি অ্যাপ্লিকেবল কিনা. এটা প্র্যাকটিক্যাল মানে এখানকারই, ঠিক আছে, এটা শান্তিনিকেতন মেডিকেল কলেজ হসপিটালে, ঠিক আছে. সো you can have take your seat, you can have a seat or whatever you feel comfortable, try to solve this one. ওকে, লেখো লেখো সবাই একটা করে খাতা. মিডিয়াল এপিকন্ডাইল দিয়ে শুরু করি. মিডিয়াল এপিকন্ডাইল কি হয়েছে? অ্যাপিয়ার হয়েছে এটা তোমরা কোন এজ গ্রুপ নিয়েছো, মেল না ফিমেল? মেল. মেল সেক্সটা লেখা থাকবে, তাহলে এটা অ্যাজিউম করবো না ফিমেল, এটা মেলই, ঠিক আছে. মেলের জন্য আলাদা ভ্যালুজ আছে ওখানে, ঠিক আছে, অলমোস্ট. আচ্ছা আগে তোমরা এগুলো দেখে নাও. মিডিয়াল এপিকন্ডাইল অ্যাপিয়ার্ড আছে, ফিউজ হয়নি. ল্যাটারাল এপিকন্ডাইল অ্যাপিয়ার হয়েছে, ফিউজ হয়নি. রেডিয়াল হেডটা ফিউজ হব করছে, অ্যাপিয়ার তো হয়ে গেছে, ফিউজ হব করছে. ওলেক্ট্রন প্রসেসটা অ্যাপিয়ার্ড নট ফিউজ, ঠিক আছে. বসো এখানে চলে এসো এবার. অ্যাপিয়ার্ড 7 ইয়ার্স. ল্যাটারাল এপিকন্ডাইল অ্যাপিয়ার্ড তো 12 ইয়ার্স, মানে 12 ইয়ার্স এর অ্যাবভ হচ্ছেই. টিপ অফ ওলেক্ট্রন অ্যাপিয়ার্ড, ঠিক আছে, তার মানে অ্যাবভ 11, মানে অ্যাবভ 12টা তো পেয়ে গেছে, অ্যাবভ 12 হয়ে গেল এখানে অবধি. রেডিয়াল হেড তো আছে, অ্যাপিয়ার হয়ে গেছে, ওটা 8. তো এই অ্যাপিয়ারেন্স আমরা 12 পর্যন্ত চলে গেছি, এক্স্যাক্ট ভ্যালু পেয়েছি 12, ঠিক আছে, অ্যাপিয়ার হয়ে গেছে, বোঝা গেল তো. এবার 7, 8 এর কনফিউশন নেই, 12 পাচ্ছি একদম এক্স্যাক্ট ভ্যালু. এবার আমরা এই দিকটা দেখি, ফিউশনে. ফিউশন মিডিয়াল এপিকন্ডাইল ফিউজ হয়নি, তো অলমোস্ট অল বিলো 16, ঠিক আছে, এই 16 উইথ শাফট বলছে. তারপর এটা 11 to 16 হচ্ছে লেটারাল এপিকন্ডাইল, এটাও ফিউজ হয়নি, তো 60 না বলছি অ্যাবভ 12 তো হলো, বিলো 16. 11 to 16 ইয়ার্সের সময় পাচ্ছি আমরা যেটা ফিউজ করা, সেই জন্য ওপরের ভ্যালুটা দেখব, ঠিক আছে. তাহলে আপাতত এখন কি আছে, অ্যাবভ 12, বিলো 16, এত দূর যতদূর আমরা করছি, ইন্টারপ্রিট করছি. তারপরে টিপ অফ ওলেক্ট্রন ফিউজ হয়নি, তো ওটা তাও ওই হয়ে গেল, 16 পর্যন্ত আটকে আছে. তারপরে রেডিয়াল হেড ফিউশন 16 ইয়ার্সে হচ্ছে, ওইটা দেখো একদম ফিউজ করছে কিন্তু করেনি. তাহলে এজ কি হলো, অ্যাবভ 12, বিলো 16. ওর এজ কত আসছে, 15, 15 হলো, ম্যাচ করলো, ব্যাপারটা হলো এইভাবে, ঠিক আছে, বোঝা গেল. এটার প্র্যাকটিক্যাল অ্যাপ্লিকেশন হয়, আর এটা কোর্টে আমাদের বেশিরভাগই করতে হয়. থাক এটা পরে, চলো আর একটা করবে, সোজা, ওটাও সোজা. টিপ অফ ইলেকট্রন 9 to কত ছিল, 9 to 11 মনে হয়, না 9 to 12 আছে, 9 to 12 আছে তো, 9 to 12, তাহলে বিলো 9 হয়ে গেছে. টিপ অফ ইলেকট্রন 9 বেরোয়নি, না 9 to 12 ইয়ার্স আছে এ করতে. আরো কাছে করতে গেলে, ন্যারো করতে গেলে, রেডিয়াল হেড কখন বেরোলো, 6. তারপরের ভ্যালুটা কি আছে, 9টা কোনটা, অ্যাপিয়ার্স 9 to 12, অ্যাপিয়ার তো হয়নি, কিন্তু 12 ইয়ার্স পর্যন্ত অ্যাপিয়ার হতে পারে. অ্যাবভ 6 বিলো 12, ঠিক আছে? 6 to 12 তাহলে অনেকটা গ্যাপ রয়ে যাচ্ছে, ওইটাকে ন্যারো করো। আর কি কি আছে প্যারামিটার্স কাছাকাছি দেখো, আছে কোনো ভ্যালুজ? নেই। ল্যাটারাল এপিকন্ডাইল 10 বছরে অ্যাপিয়ার করে বিলো 10, তাহলে 12 থেকে এখন 10 কমে গেল, আরো 2 কমে গেল, আরো কম করার চেষ্টা করো, হচ্ছে কিনা দেখো। অ্যাবভ 6 বিলো 10 অবধি হলো এখন অবধি। ল্যাটারাল এপিকন্ডাইল তো হয়নি তো, বেরোয়নি তো, তাহলে আমাদের এইভাবে ন্যারো করতে হবে, একটু ন্যারো দিই। 6 to 10, ঠিক আছে, ঠিক আছে। এইবার examiners might ask you, if you are able to answer this, আরেকটু ন্যারো করার জন্য আমাদের আরো 2-3টে প্যারামিটার আছে, সেগুলো হচ্ছে ওই ক্যাপিটুলাম, ট্রক্লিয়া, এইগুলো। তো ওগুলো অতটা লাগবে না তোমাদের জন্য, এইটাই ঠিক আছে। এই 4টা পড়ে এটা উদ্ধার করে দিতে পারলে এক্সামে সবাই খুশি হয়ে যাবে। ওই ট্রক্লিয়া দিয়ে আরো কমানো ওটা মুশকিল আছে, কিন্তু হয়, করা যেতে পারে। কেন কি ট্রক্লিয়া, তারপরে ক্যাপিটুলামটা এখানে নেই, এটা তো উইথ ক্যাপিটুলাম আছে, এইগুলোতে আরো ন্যারো করা যায়, ঠিক আছে ভ্যালুসগুলো। বাট দোজ 4 ইনাফ ফর এলবো জয়েন্ট। কি কি? মিডিয়াল এপিকন্ডাইল, ল্যাটারাল এপিকন্ডাইল, টিপ অফ অলিকুলার প্রসেস, রেডিয়াল হেড, বাস এইটুতে তোমাদের এলবো জয়েন্ট কভার হয়ে যাবে। আর ওতে মোটামুটি অলমোস্ট অ্যাকিউরেট আসে, অলমোস্ট, ঠিক আছে? কেন? ল্যাটারাল এপিকন্ডাইল, ল্যাটারাল এপিকন্ডাইল ল্যাটারাল এপিকন্ডাইল অ্যাপিয়ার করেছে, ঠিক আছে, ঠিক আছে। এটা 10 ইয়ার্সে, এটা 10 ইয়ার্সে। আর বিলো কত বললে? বিলো 12, বিলো 12 কেন? এটার ফিউশন এজ কত? ফিউশন কি এ আছে ব্র্যাকেটে? 10 to 12 ফিউজ করেন। মিডিয়াল এপিকন্ডাইলের ফিউশন কখন হয়? 14 উইথ শাফট, তাহলে ওটা হচ্ছে না, ঠিক আছে তাহলে।